right, good morning. It's Wednesday, October 5th. I'm Dr. Steve Stice, Chief Medical Officer here at the University of Kansas Health System. Delighted to be back with you on this program of Show Me the Science. In keeping with our Pink Week, dedicated to breast cancer awareness, we're going to break down a disturbing trend in one aggressive cancer being diagnosed more than twice as often in black women than white women. And scientists believe a gene mutation is part of the problem, but not the only problem. Our expert today is Dr. Joan Lewis-Wambe. We're just going to call her Dr. Wambe, or I may just call you Dr. W. You never know what's going to come out of my mouth in these programs, so be careful. A tenured associate professor in the Department of Cancer Biology here at the University of Kansas Medical Center. We'll also be hearing from Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, who's going to be joining us in just a few minutes with a COVID count, and then we're going to talk a little bit of COVID at that point. Today, we will be showing you the science from 4 reputable sources: the American Cancer Society, Susan G. Komen Foundation, the Annals of Internal Medicine, and the National Cancer Institute itself, that have all recorded a higher rate of triple-negative breast cancer among black women. We're going to talk about what triple-negative means. These studies looked at cancer registries of patients from the ages of 20 to 84, spanning multiple years. So what is triple-negative breast cancer? Well, first of all, it's not the one you necessarily want. Did you ever want any kind of breast cancer? Susan Komen defines TNBC, triple-negative breast cancer, as a cancer that does not have any receptors located that are commonly found in other types of breast cancer. If you think of cancer cells as a house and the receptors as 3 different locks on the front door, triple-negative breast cancers lack the most common types of receptors that fuel the most common breast cancer growth: estrogen, progesterone, and HER2 proteins. So think about the locks on the door, and if we want to use chemotherapy and things, we got to unlock that door. But if you don't have them, it's harder to unlock. Dr. Lewis-Wambe, researchers with the University or with the National Cancer Institute, noted that triple-negative breast cancer among black women also varies based on where they were born. How does this birthplace impact this cancer diagnosis? And is this true only for black women?
Well, I think it's not just for African American women or women of African ancestry. I think we've looked at data looking at Asian women who live here in the United States versus China or Japan. And it seems as though when they move here, they have a higher incidence of triple negative or other types of breast cancer. And so breast cancer is really, it's a disease of subtypes. And so the most common breast cancer is the ER positive or estrogen dependent breast cancer. Triple negative is a more aggressive subtype, and it's the type that doesn't have any estrogen receptor, progesterone receptor, or HER2 receptors. And those breast cancers, we have targeted therapies for them. But triple negative, we do not have any targeted therapies. So patients are usually treated with surgery, radiation, and chemotherapy. So there are lots of side effects associated with breast cancer, and there's also a higher risk of relapse for those patients. We know that African American women are twice as likely to be diagnosed with triple negative compared to the other subtypes of breast cancer. And so one of the questions that our lab is interested in is what is driving this higher incidence? And there's a higher mortality rate among African American women. They have a 40% higher mortality rate for all types of breast cancer, which is very disturbing for all of us. So really trying to understand the biology of the cancer. What is it within this triple negative tumor that makes it so highly aggressive? And then how do we bring down that mortality rate? And the key to that is early detection, obviously, and we're in the month of breast cancer awareness, and we cannot overemphasize the importance of early detection, because you detect the disease early enough, we can treat it. If it's detected late, then we're limited in our treatment options. And so the idea that zip code may play a role has been around for a long time. We know that individuals who live in certain zip codes have a higher incidence of breast cancer. And for triple negative, we've even looked at Wyandotte County compared to Johnson County and some other counties here in Kansas. And individuals in Wyandotte County have a higher incidence of triple negative and other types of cancers as well. So there is something to this idea that where you live may also impact your risk of getting breast cancer and also your overall mortality for the disease.
So tell me a little bit, why would where you live influence how often you have triple negative breast cancer?
Well, I think breast cancer we know that there are risk factors, and these risk factors, they impact who will get it, how aggressive it will be. There's no one factor that we can say definitely determines whether or not a person will get breast cancer. But for triple negative, we know that breast density is important, your environment, your diet is important, your access to, you have to be able to exercise, so being in an environment that allows that to happen. Stress is also an important factor. And what we're exposed to in the environment is also very important. I think we do not have a good sense as to what we're exposed to on a daily basis. And so all of these factors may contribute to triple negative and the other types of breast cancer. So the idea is that your zip code by itself is not what's driving triple negative, but your exposure to certain things within those communities may be what's driving it. And so we look at not just the biology of the cancer, but also what is in the environment that's also contributing to it. And I'm a cancer biologist, so I'm mostly focused on the genetic aspect of cancer. But there are lots of research that's focused on your environment, the diet, stress. There's so many other factors, your access to healthcare. And I think it's very important that we should also address that, because the higher mortality rate has to do with later detection and then not having access to those treatments which are important to increase your mortality or decrease your mortality. So it's a combination of things, but we can't study everything all at once. We look at the biology and the genetics of it, but we cannot ignore access to healthcare, access to the more advanced treatments that are available for patients with breast cancer, and then your diet. What does your diet look like? How accessible do you have to exercise or to be able to do things that can help you reduce your stress and keep moving? We know that exercise is also beneficial for cancer patients. So it's a combination of things, but we know that we cannot reduce our mortality rate if we don't have better access to care, we don't have the means to detect breast cancer at an early stage.
You know, it's interesting because I'm a cystic fibrosis doctor and take care of a lot of CF patients, and it's so similar to the story within CF. We may know the gene defect. We know that gene defect is responsible for lots of lung disease and other problems from CF, and yet two people with the same gene defect have much different expressions of that gene and how well they do. And then you start turning to what are the other factors that affect it? What about diet? What about exercise? What about lifestyle? All those things seem to impact. So Dr. Lewis-Wambe, talk to us about tumor biology for a moment, because not all of our listening audiences or watching audiences are going to know about tumor biology. Researchers discovered that 46% of black women had a TP53 gene, you have to tell us what that means, TP53 mutation, compared to 27% of white women. What is TP53? How does it affect your chance of getting breast cancer? It's just another one. This is really a story about genetics here, and the intersection, I think, with genetics and cancer.
Yeah, and this is very interesting. So TP53, it's a gene that's the guardian of our cells. And so it's a tumor suppressor. It's there to actually help our cells to maintain order. And so normally our cells, they'll divide and they do the things that they're normally supposed to do. Cancer comes about when TP53 or P53 is mutated, and it's not allowed to do its main function, which is to guard our cells from replicating when the DNA is damaged. And so by mutating P53, these cancer cells are able to keep replicating even though the DNA is damaged. And so we know that in African American women, 46% of them have a P53 mutation. So that can make them at an increased risk of getting the cancer. But P53 is not the only gene that is linked to cancer. P53 is mutated in all cancers. I think actually 80% of cancers have a P53 mutation of some kind. So that's important. But we have other mutations that's also happening. The BRCA1 mutation, I know a lot of you may have heard of BRCA1, BRCA2, and that's the breast cancer gene that's usually associated with a higher risk of breast cancer, usually in younger patients. So we know that in African American women who have triple negative, a high percentage of those women have a BRCA1 mutation. So genetics is important. And so understanding how these genes, how they are regulated or dysregulated in the tumor is also important. And how does that impact how you respond to treatment? That's also impactful, and that's something that we have to study. But yes, P53 is an important gene. It's the guardian. It's one of the guardians of our cells, and it helps our cells to maintain order when it's dividing. And if there's any kind of DNA damage, it prevents the cells from keep replicating. But when it's mutated, the cells just keep replicating. And so the idea is that there's focus on trying to find drugs that can actually target these P53 mutations within the cancer cells. We're not there yet, but there's lots of efforts to try to see if we can target it. The BRCA1 mutation, we know that there's a specific drug, a PARP inhibitor, that's currently available that targets that BRCA1 mutation in triple negative. So that's been FDA approved for a subset of women who have a BRCA1 mutation in triple negative. So understanding the biology, understanding how genes intersect with the environment and other factors is critically important to not only having a better idea of what's driving these cancers, but then how can we potentially treat patients that have these specific mutations in their tumors.
So you said a term that I want to come back to. You talked about DNA damage. And it's kind of like, is that where diet and environment and exercise and sun exposure, and is that a route for DNA damage to occur when we eat like lots of bad food? For example, I may happen to love Gates barbecue. Maybe I just love barbecue. But it's a lot of smoked meat.
Yeah.
So you have to be careful because that's not good, because I know that it can cause DNA damage leading to colon cancer. So talk to us a little bit about what does DNA damage mean?
So when we say DNA damage, and DNA damage can happen from our diet, from our exposure from sun, there are different ways that we can be exposed to DNA damaging agents. And what that means is that our DNA is the guardian of our genetic information. And if it's damaged, we have lots of DNA repair enzymes in our bodies. And so our cells need these DNA repair enzymes to work. So when we're assaulted in terms of these different DNA damaging agents that are present maybe in the foods that we eat or present in the environment that we're exposed to, we have to have a way of repairing this DNA damage. Now, when these DNA repairing enzymes are mutated, when they're no longer functioning, then the DNA, it's damaged, but the cells can keep replicating, which is not normally what happens. If DNA is damaged, usually the cells will stop, and that's where P53 comes in. It tells the cells, stop. You need to stop dividing. You need to repair, and if you cannot repair, then you need to die. The cells are supposed to die if they're so badly damaged that they cannot be repaired. But when you have these different types of mutations and these different insults that happen, they overwhelm the cells. And so the cells are not able to repair those damage. And so they keep replicating, and that's how we have cancer. So the idea is that there are many things that can lead to DNA damage. We're exposed to many things in our environment, in our diet. It's hard to quantify what that exposure is, what that risk is. And so we know that exercising is good. Eating a balanced diet is good. I love Gates.
Yeah,
but
it is good, isn't it? Q39, good. Gates.
Yeah, but it would not be good for me to eat it every day or every week. So having a diet that's balanced, having high fiber, eating lots of vegetables, lowering your saturated fat intake, that is also beneficial, because there are lots of studies that have shown that obesity increases your risk for all types of cancers. And so we know that colon cancer is on the rise, pancreatic cancer is on the rise, and breast cancer, we know that obesity is linked to triple negative especially.
And we know that African American women often live in a different socioeconomic status, and that diets are different. And especially in areas where there may be food deserts, you tend to not have access to the higher quality food, or fast food becomes a more frequent thing. And all those a lot of high fat content, a lot of preservatives, a lot of salt, a lot of fast food. That's like the recipe for a bad diet and for DNA damage.
Oh, absolutely, absolutely. And I cannot stress enough how important it is to have access to healthcare. Obviously, we have to have access, and so early detection through mammogram, that is important. But diet is super important. We all know what we should do, but the challenge is in some neighborhoods there's no access to fresh vegetables or healthy food, or it's very expensive. And so the reality is that even though we say that we need to eat more healthy, we need to exercise, we need to do all these things which we know are beneficial, we have to be cognizant of the fact that not everyone has access to those things. And so eating healthy, very important, but making sure that individuals have access to healthy food and having access to trails. I live in Overland Park. We have lots of trails. It's great to get out and to walk and to be exposed to fresh air and have trees and breathe the fresh air. And so that's beneficial. But diets that's high in fat and high in sodium, it's usually not helpful in terms of your risk for cancer, but other types of diseases. And we know that obesity is linked to diabetes, and that's also linked to breast cancer as well. So it is a combination of things. But it starts with the biology of the tumor, because the tumor feeds off of whatever is in our body. And we have to make sure that we're feeding our bodies with healthy things so that we're able to counter the negative effects of the tumors. But yes, diet is very important in this regard.
Well, it's if we were to break it down, and we'd call it PDAT. Watch out, everybody! I got a new thing going on here. PDAT: prevention, detection, access, treatment. So we've talked a lot about prevention. We also know that detection is important. One of the struggles we've seen is that mammography fell off tremendously during the COVID-19 pandemic as people people just didn't come get health care. Unfortunately, the rates have not returned. And so I think that we're concerned because we're starting to see these rises in breast cancer across the country, but especially in communities of color, because we know that folks don't get that same level of care because the access isn't as good. Talk to us a little bit about that. Do you guys ever look at the impact of access on cancer?
Well, I do not specifically. I have some colleagues who are looking at that because I know that that is a big challenge. I spent a lot of time interacting with individuals in our different communities, and one of the things that they always tell us is that, you guys tell us that we need to go and have our mammograms and make sure that our cancers are being detected. But even if we do, we don't have access to all the necessary care, or they have other issues that they're dealing with. So detection is super important, because we know that if you detect cancer early enough, if it's stage 1, stage 2, the treatment options are much better for those patients. The overall survival is significantly greater than if you detect it later. So if you detect it stage 4, where it's already metastasized, you're limited in your treatment options, and your overall survival for those patients with metastatic disease is very low. So early detection, better treatment, overall survival is usually 80%, 90% for breast cancer, which is ER positive. Even for triple negative, it's around 70%. But if you detect it late and it's already metastasized, then the survival rate is about 15 to 20%. That's dramatically different. So early detection is the key, but having access to treatment is also very important. And that's been one of the challenges we faced with trying to get the word out that you need to go get your mammogram, you need to have early detection, and that will help you to get good treatments. But we've heard consistently from a lot of individuals, like, even if we go and we get detected, we don't have the same access to all the treatments that's available to other people.
We know that many communities, and there's a lot of, I think, data that also talks a little bit of the same stories in rural communities that don't have as good access to therapy, and also some of the same dietary challenges with fast food or food deserts or hard to get to, et cetera. And so you end up having more preserved foods, and all those things lead to a less healthy diet, and that a less healthy diet has an impact on and can lead to obesity. So when you look at all those factors, you have to recognize, okay, again, prevention, eating healthy, detection, getting your mammogram so that you are, but that also defines access, because it's not only can you get your mammogram, but can you get your health care? And then the treatment itself, is if you can't get follow-up, or you don't have insurance to help afford it, or you have a high copay, all those things become deterrents to getting care, and all that combines to a more difficult outcome. It's not only true about breast cancer, it's true about lots of different types of diseases and health, and it's part of the disparity and part of the brokenness of the American healthcare system, unfortunately, is that all these factors can lead people to have a less healthy life, and when they do, they can't be engaged in society, they can't work, they can't raise their families, and then we all suffer the tragedy of that, I think. So more than one study has pointed out to the impact of COVID-19 on mammography volumes, which have still not returned, as we mentioned earlier, to the pre-COVID-19 levels. I think there's a struggle that goes on around that. In fact, there was one study in the Annals of Internal Medicine that published research showing that black women began mammography every other year. Starting at age 40, breast cancer deaths could be reduced by 57% compared to if folks started 10 years later. How are we going to accomplish that? Well, clearly we need better access, right? We need to have more education about the importance of that, and we need to have our ability to take that information and get to treatment. Because even if you know you have cancer, if you can't do anything about it, then it becomes very difficult to say, okay, well, we've made a difference. So there's so many societal factors that blend into this story a little bit. All right, so we're going to get to some of our questions. We know there are a lot out there. But first, Dr. Dana Hawkinson, Medical Director of Infection Prevention Control and Infectious Disease Specialist here, is going to give us our viral updates today. Viral updates, COVID updates. How about that?
Viral updates, yeah.
Yeah, there you go.
Well, 34 active infections in the hospital right now, with 4 in the ICU, 2 in the ventilator, 19 in that recovery period. Again, Steve, we've really just been, unfortunately, hanging out in that low 30s.
We are.
That is really the gist of it for the past several weeks, actually.
And you know, if we were screening everybody, I bet we'd be in the 50 or 60 range. But we don't screen everybody. We only do the symptomatic now. We've been doing that since May or whatever. Yeah. And yet it's still high. And you watch the U.S., the numbers are dropping. Yeah. But talk to me about this BA2.75 variant, because we're seeing those numbers rise, and in some countries in the world it is now the dominant variant. Should we expect that in the U.S.?
Yeah, I mean, I think we should, and we can, or other variants. You know, we know if you look at any of the websites that have the variants in the time period, you will see specific time periods for Alpha, Delta, Omicron. You know, the BA2.75 is really an offshoot of that BA2. So I thought it was New England Journal maybe last week, still had some information published. You know, right now it still looks like our therapies work. The vaccines, this virus is now becoming resistant to those immune responses that the vaccines produce and elicit. So I think that's all good news. But I think what it is it's just it's a vacuum that you have people who are really immune to one isolate like BA5 because they've had it. And so you don't have as much immunity to some of these other ones, even though you do have immunity. And so it's easy to get infected. I think really, as you have been saying for quite some time, we really need to look at hospitalizations and death. Yeah. And the vast majority of hospitalizations continue to be those that are unvaccinated, not up to date, and with significant comorbidities. So.
Yeah, I think that's really the key. And I did read that article in the New England Journal, and it said, gosh, high neutralizing antibody titers may be a little more transmissible, but really responds to all the therapies, Paxlovid, all the different monoclonal antibody therapies. And so I think it is not unlikely we'll see a rise in BA2.75, but I think we're prepared if we just do the things we know that work. First of all, the rules of infection prevention control, which continue to follow you wherever you go, but also vaccination, which is an important topic. Speaking of which, oh boy, here we go, baby. We've talked quite a bit about the importance of getting your COVID boosters and the flu vaccine. It's time for us to once again show you how easy that is. I want to bring in Nurse Manager of Occupational Care, Vanessa McMillan, who has arranged our vaccines today. Vanessa, with our booster, do we still need to wait the 15 minutes like the other COVID vaccines?
Hi. So as long as you haven't had any major reactions to
Nope.
the previous vaccines, you're good
Oh,
after,
good.
and
Wait,
you don't
wait, wait.
necessarily have to wait
Vanessa,
those 15
here.
minutes.
Does dorkiness count as a major reaction? Because if it does, I'm in trouble. In fact, I was down today in the cancer center getting my routine follow-up for prostate cancer, and they put a full risk label. I just want to show this. I was labeled as a full risk.
Yeah.
I said, why am I a full risk? I took a picture, said to my wife. You know, my wife and I are like a week apart in age. She said, well, you're just too old. She was down there doing some other stuff, and she didn't get a full risk tag. I got a full risk tag. What is that about?
I think the dorkiness is the pre-existing condition.
Do you think that's it?
Pre-existing.
Do you think maybe just being gawky is the reason that you get a fall risk tag? Okay, so now that we've established that I have a fall risk and I'm a dork, we're going to talk a little bit about getting this bivalent vaccine, and I'm going to get my flu shot and my vaccine. Hawk, you're just going to get your flu shot today.
Just booster today.
Booster, okay, got
I'm
it.
going to
All
hold
right.
off on the flu probably for another 3 weeks.
Okay,
and
it's just a different. You could do either one though. You can
Yes.
get both today or
Yep.
not. I just decided I'm gonna get all my pain over at once. Okay, now here comes the real trick. I have to take off
Yeah.
my white coat and unbutton my shirt, and you're gonna see how completely dorky I am once I do that. And so we'll see how that goes for everybody. So while I'm getting ready, Jess, are there any reporter questions on the line today?
Are no reporters right now, but I could ask a couple of questions.
Okay, you do
To
that
our
because in
guests.
just a minute I'm taking my shirt off here.
Oh gosh.
That's not a
okay.
thrill, trust me, people.
We're
If I
all
were you, I'd
watching.
turn your cameras off on your show, turn down the color, turn down the whatever, and
Wait, are you?
that's
Do
better
you have
for
the white?
America.
Do you have the white T-shirt on? You say?
I did. Dang it! Don't bring that up. I got the
Sorry.
tidy whitey on today. Okay, it's just
Okay.
what I put on. I kind of forgot I was doing this, and I may have dressed a little differently if I'd remembered.
Okay. While you're doing that, whatever you're doing, as you're taking it all off, I'm going to talk to Dr. Lewis-Wambe. How does that sound?
Please.
Okay, so Doctor, I have a question. Juan wants to know, can environmental factors like deforestation and wildfires cause gene mutations that lead to an increase in breast cancer? And we've talked about other factors. What about environmental?
I think that sounds like climate change.
We
know
climate change. I mean, climate change impacts different types of cancers. I don't know if it's specific for breast cancer, but I know that I don't know if there's any specific study that links climate change specifically to breast cancer, but we know that just environmental factors can impact your risk for breast cancer. So, yeah. There are no specific studies that I can quote, but we do know that in terms of, I don't know, the air we breathe. I mean, it's probably more in terms of lung cancer rather than breast cancer, but I don't think we've looked specifically at environmental factors related to global warming or things like that. To breast cancer.
We know just from the hurricane right now, Hurricane Ian in Florida, post-hurricane, there's more mold. And that's led, that the type of mold is linked to the climate change that's occurring. We know that mold causes lung disease. The different lung disease lead to lung cancer. So I think I think there is a clear association. And again, when we cheat the environment, as right, whether it's our own personal environment. Oh Lord, that is a really ugly picture on that camera. Oh my God! Let's get this shot over with. Which is the first one so I get dressed again? Just stop laughing, Jess. That is not kind.
No, I'm taking.
You are just
I'm taking,
laughing. Don't you
I'm
dare.
taking a picture of the screen
Ay, vey.
because I have to send that to you
Let's
later.
get
We'll do
this
your
stab
COVID
me
first.
That's
quickly.
One, two,
Emmy-worthy.
three.
That's Emmy-worthy right
Thank
there.
you.
Oh my gosh, this
Okay,
is
But it's
fire
done.
off.
Okay,
Wait, I'm going to look like Hawkeye. All right, let's go.
It's the tie.
I'm going to sit up straight.
Yes.
I'm going to try and help the world here. Jess, you're just laughing out loud. Don't even try to put the hands together. Don't act like you're
I
praying.
know.
That's tough. Okay.
Sorry.
Fine. Look, can we get this?
I can't look. I can't look.
That was your COVID. All
So I
done.
got COVID in. Now I'm going to get influenza. Just a second. She's going to go to my other shoulder and do that one.
Can she hurry?
Yeah. Really? I'm going to sit up straight and puff my chest. Take a deep breath.
I rather like
Here we
this
go.
look you have.
Thank
going
you.
on.
How about that? I wore my tank top so I could look a little more like Hawkeye. How's that work? And please turn down the brightness in the room. Turn the lights off. Let's go, people. Get this thing done. I got a fall risk, I got a white tank top on, I'm being exposed, and now I'm dorky, and I got Jess
1, 2, 3.
taking pictures of me the whole time. Thank you,
Oh,
Jess.
my flu shot is also done.
All right, I am fully vaccinated. Jess, are you fully vaccinated?
Are you
Have
fully
had your flu
clothed?
shot?
You're fully vaccinated. I need you fully clothed.
Well, I'm going
And then we
back
can
at
move
it right
on.
now. Okay, there we go. Thank God. I'm going to take the brightness away. I'm going to get back to that. I think it's Hawkeye's turn now. Let's divert the camera. In the meantime, let's ask Dr. Wambe a question.
Okay,
Can we, please?
I've got one for her. So Marcia wants to know if triple negative breast cancers present the same as other breast cancers. Do they present the same, or are there different symptoms that women should look for?
So probably not. So the symptoms would probably be similar, and most women that's diagnosed with triple negative or ER positive, it's usually with a detection of a lump. And so through either self-examination or through mammography. So having your mammogram, it would detect it the same as it would with ER positive or HER2 positive breast cancer. So triple negative is only diagnosed through pathology. And so you would take a biopsy of the tumor, and then you would look for these markers. And so if it doesn't express the estrogen receptor, progesterone receptor, HER2, then it's described as triple negative. It doesn't have those 3 receptors. But in terms of symptoms, you really can't tell based on your mammogram if it's triple negative or ER positive. You would have to do the pathology analysis of the tumor.
Okay, Jess, hang on. Here we go. I've got my tie back on. I'm decent again for the most part. And now it's Hawkeye's turn.
Yeah.
Hawk, how's it going over there?
It's good. And I was just informed, too, that this will be Pfizer. So, again, previous vaccines were Moderna.
Yeah, and that's just because the Moderna shot hasn't ramped back up yet,
Still,
I think.
yeah.
So we're still a little in short supply. And so you're going to get the Pfizer vaccination as I did, and here we go.
All right, ready?
Yeah.
1, 2, 3. You are all done, sir.
All right. Thank
Thank
you.
you.
All right.
Hawkeye,
Easy.
are you a fall risk?
Not yet. A couple years.
Yeah, there you go. Okay. All right. I got a little collar malfunction. Jess, go right ahead while I'm figuring that out.
I will carry on. So let's see. We've got Yen Liang wants to know, do we have any new chemotherapy treatments or drugs for triple negative breast cancer?
So right now we have as I mentioned earlier, so about 60 to 70% of triple negative has the BRCA1 mutation. And so there is this drug called a PARP inhibitor, or olaparib, that targets this protein that's dysregulated in triple negative. And so that's been FDA approved for the last several years. And so that would be considered targeted therapy for those patients. So in terms of chemo, it's just the standard chemo that patients have been on for years, and those have worked really well. And one of the things about triple negative is that it responds really well to chemotherapy. And so I should make sure that that's clear. So patients who have triple negative disease, they're treated with surgery, radiation, and chemo. Chemotherapy works really well in those patients. The issue is that for a significant proportion of those patients, they exhibit relapse, and so the triple negative disease comes back. And so the idea is that if we can have better targeted therapies, we can reduce just the side effects that's associated with chemo. And that's usually the challenge, because chemo works really well, but it's not only killing the cancer cells, it's killing all of your healthy cells as well. And so there are lots of side effects associated with that.
Kay has a
Jess,
question.
I think that comes back to the that locked door question. You know, what are the locks on the door? Can we unlock it or not? And if we can't unlock it because of those negative receptors, then there's a problem, and so then people don't fare as well. So I haven't fainted yet. I want to say thank you to Vanessa McMillan for coming in, putting up with my dorkiness and the fact that I'm a fall risk. Do you have scissors so I can cut off my fall risk tag now?
I don't have scissors with me. I'm so sorry I didn't bring any.
Maybe I'll get Jess to cut off my fall risk things a little later when she's done laughing. Do you think that's possible?
Possible.
Yeah, I don't know.
I would love to do the honors.
Yeah, you bet. Thank you.
I will.
Thank you so
Thanks
much.
for coming in today. We haven't fainted yet, and I haven't fallen off the chair yet.
Thank
Okay,
you.
Jess.
We will keep an eye on you. Okay, so 2 more questions, and they're both to Dr. Hawkinson. Kay wants to know, she says, I've had thyroid removed because of cancer. I'm taking the radiation pill November 2nd. When can I get my second COVID booster and my flu shot to be safe? Should she wait? When should she do that?
I think you can get it now. I really don't know that much about the the pill that you're taking. I don't know if it's a targeted iodine. Yeah, so I think you should be okay. That really shouldn't affect the other any other aspect of your immune system. Certainly, get the final word from your physician that's prescribing that. But I think anytime you really want to get it, that really should not interfere, as far as I know, with that immune response that will be generated from both of the vaccines. So certainly getting it now or waiting. Like I said, I don't believe that medication that you talked about is really going to affect any immune response necessarily. Get the final answer from your physician, but you can get the vaccines at any point.
And then
Jess,
Gretchen,
we're all clothed again, so all
thank
is good
you.
now. Yeah,
Okay.
so yeah. I see you taking a look at the screen to see what it looks like.
I am. I'm like, I don't want to look, but all is right in the world. You guys are all
Yeah,
clothed.
okay, good.
I like
saw you
that.
try and close your eyes. Go ahead.
The last question, and we haven't talked about this in a minute. Gretchen wants to know, Dr. Hawkins, I'm just curious what's going on with monkeypox. Do we still think we might need a vaccine, or is this old news? What's going on?
Yeah, it really seems like the cases are going down. In fact, I was just looking at a recent publication from MMWR from last week showing good protection from Jynneos from even one dose of the vaccine. So, so far the early data continue to support the fact that the vaccine works. But right now, overall cases are going down as far as reported cases in the United States and around the world. So overall, that's a good thing. It doesn't seem like there are any new recommendations right now for any other non-risk or low-risk populations to get the vaccine.
You know, I think the other thing just to think about as we look at the numbers declining around the United States for COVID, which is great. We'll see what happens because the weather's starting to get cold, right? Come Friday when it's a high of 55 degrees here in Kansas City, and people start going back inside. That's, I think, the next big challenge, especially as we see the BA.2.75 variant begin to escalate, which I think most of the folks I'm reading says, gosh, we expect that to become a dominant form before long. So will that change things? Hawkeye, talk to us about a couple things first. Number one, lots of patients coming in with their second or third episode of COVID. Does that mean their immune system doesn't work? Or what does that mean to you?
Well, number one, I think it's unlucky that they've had their second or third episode. But I would not say no that their immune system doesn't work at all. You know, once you have really those 3 exposures to spike, whether it's 3 vaccine doses or 2 vaccine doses and an infection, really from there we have seen the greatest improvement. Now, certainly if you're older, needing that booster to help reduce your risk even further of hospitalization is good. But unfortunately, yeah, several people, many people have had 2 or 3 infections with SARS-CoV-2. Unfortunately, it doesn't necessarily pretend or tell you anything about your immune system other than, you know, if you get it and you're doing well, it's probably because of that immune response and you've generated a good immune response. But people in the hospital also, you know, again, we have to look at their comorbidities, things like that. Certainly things like age, obesity, diabetes, heart disease, lung disease would put you at greater risk. Not necessarily to get more ill, but certainly feel those symptoms where you need to come to the hospital and at least get looked at and get some care.
Yeah, I think that makes complete sense. And you know, the other thing I mentioned is that we have to remember that SARS-CoV-2 is incredibly transmissible.
Yeah.
And just because you've had it doesn't mean you're not going to get it. Right. What vaccination does, it helps prevent severe illness and death, which it has been inordinately powerful against. And we just have to recognize how important it has been. And then I think most of the patients I've seen who have had 2 or 3 episodes of COVID, it does tend to be milder, but a lot of them have been vaccinated as well. So again, you can still transmit, but that doesn't mean you're going to get really sick. The folks who are getting sick, the people still in our ICUs, the patients still dying, overwhelmingly have either advanced disease or have never been vaccinated, or a combination of both of those things. Okay, so I'm going to turn back to Dr. Wambe for just a moment. We've talked a lot about all these triple negative things and breast cancer. It feels like the whole field of genetic treatment and genetic diagnosis in cancer has exploded. You know, just a little while ago, we had some stories about rectal carcinoma and the impacts of new therapies with certain genotypes. I know in cystic fibrosis, if you have certain genotypes, there's some incredibly effective therapy now. Man, what do you see coming? Are we going to be able to repair the damaged gene in our bodies to help make things better?
I think that's the hope. I think we're all, with the Cancer Center getting the comprehensive status from NCI,
Yay!
it's our hope that we will be able to personalize care for patients. And it's the idea that you can look at an individual, look at their genes, and be able to cure them of whatever disease that they have. Cancer is, we always say it's a disease of omics. And so we look at the genome, so we do genomic studies, we do proteomics. So looking at your genes, looking at the proteins that are being coded by these genes tell us a lot about the cancer and the types of treatments that we can come up with. So I think definitely we're moving in that direction where it's a multi-technology approach where we're looking at not just your genes, not just your protein, and not just the environment. How are all these things working together to promote the cancer, and then how can we tackle it? Like what can we exploit within the tumor for better treatments? And that is the idea, that we can personalize care for each patient because we're all individuals. And so we make general statements about cancer, for breast cancer, for colon cancer, but we know that each individual has a unique genetic profile, and that profile dictates how aggressive that cancer is going to be. That profile dictates how well that patient is going to respond to treatment. One patient may respond really well to a certain standard of care, whereas the other patient may not respond as well. And so understanding that tumor, understanding the body in which that tumor is in, influences what we can do for the patient. So I definitely think we're moving in that direction. We're not there yet, and a lot of the technologies that we have are super expensive, and they're only available at certain institutions. But the idea is that as things become more widespread, that we're going to have better access to a lot of the technology to be able to provide that personalized care for patients. So that is the hope, that we're going to be able to find a cure. But since we cloned the human genome, we thought that we'd be able to figure out everything about the human body and be able to come up with all different types of cures. But the body is interesting in the way that it functions. So we're moving towards that goal in terms of developing personalized care for cancer patients. And so I think we're making strides in some cancers versus others. We've made a lot of progress with breast cancer. We can see that right now, if it's early detected, the overall survival is about 90% for most patients. So early detection is really the key, but combining the biology of the tumor with early detection is probably the way to go.
And I would say to our audience out there, don't hesitate, don't wait, don't let delay decide your fate. Make sure you stay on top of all of these areas, because it really, it does make a difference. I lost my mom when she was 52 and I was 19 from lung cancer. She was a smoker, and I just look back at that and I think, what would my life, how would it have been different? How would my children been raised different? How they'd had that connection to my mom, and if therapy had been where it is today, could there have been a different outcome? But if you hesitate and you wait, if you delay, it's going to decide your fate. So don't do that.
Don't do that.
Get the care that you need. All right, Jess, any other questions we want to hit right now? We good?
Nope. I'm going to let you wrap it up.
All right, thank you very much. We're going to turn now to our final thoughts. First of all, Dr. Lewis-Wambe, I want to thank you so much. This has been a great program. I love Show Me the Science because I learned from it, I learned from our guests, and I've learned a lot today from you. So thanks so much for being on our program today. What are your final thoughts you'd like to leave our audience with?
I would say early detection is the key, and we do not have to be afraid. I think a lot of it is fear. We don't want to know, because once we know, we have to do something about it. And we may not always know what we can do, or we may not have access to the treatments that we need. But early detection, we've seen time and time again, that is the key in order to dictate how well you're going to do in your overall survival. So there's nothing to be afraid. We've made a lot of progress in terms of breast cancer and other cancers. So just knowing your risk, being proactive and taking care of yourself so that you can then be around to take care of your family. That's super important. We always prioritize the health of others, but it's very important that we prioritize our health so we can be present for our families. So I would definitely tell our women audience to go get your mammogram if you haven't gotten them already. Just be proactive and to be on top of your health and not take anything for granted, and keep moving. exercise is good. It's good for all of us. So that would be my final thought.
I love it, and you're welcome back anytime. Thank you for being on the program.
Thank you.
I appreciate
Thank you
the
for having
science.
me.
It's awesome. Hawk.
Yeah, I mean, I think the message for today and this week, and really a lot of what we do, is prevention. And it's prevention with get your screening, as we've heard, get your vaccines. But also the other aspect of that, just a very poignant aspect, certainly, is that access. And we want to continue to give access. Please, if you know people who need that, there are resources out there. Please get your vaccines. Get those preventive screening tests done, and work towards getting that access so that you can live a healthy life, have a good quality of life.
I am always reminded about the intersection of faith, hope, and science. When we delay, we let delay decide our fate. When we don't act on what we know is the best way to take care of ourselves, we challenge that triangle of faith, hope, and science. But we know if we take good care of ourselves, we access care, we provide care to everyone, that intersection of faith, hope, and science becomes more powerful, not just for the one, but for all of us. And I think that's perhaps one of the most important messages of the day. Our genes set us up for things, but our lives determine how we let that happen. Faith, hope, because we believe there are new therapies are coming. Just look at CF. Oh my gosh, it's such a remarkable thing to sit and tell someone who's supposed to die when I started in CF at age 17, and now you're saying start saving for retirement because you're going to live that long. Faith and hope and science is just so powerful. Hey, we want to bring back Vanessa McMillan in for just a minute. Vanessa, I haven't fallen out of the chair. A, am I still a fall risk?
I think you're good.
Oh, thank God, I can take the darn thing off. B, has it been our 15 minutes? Are we okay to go?
Yes, you look great to go.
All right.
I would like to remind everyone that
I want you to say that again, so I want to make fun of Jess. You said I look great. So there,
You
Jess.
look great, yes.
Despite the tidy white. Okay,
yes,
keep going. Sorry.
I did just want to
All right.
remind everyone in the health system that flu shot season has started, and you can
Yes.
come get your flu shots at all of our mass flu vaccine events, and we will also have the COVID vaccine booster available. So if you're an employee or you work for GME and are a physician, or you're one of our fellows or residents that are working in our health system, please come get your flu shot. You can find all of that information on 24/7. Remember that your flu shot is due in occupational health by October 31st. So if you did get it outside of the health system, please let us know so we can get that into your employee health file.
Hey, HR's not going to come for me this year. Awesome.
Yeah.
All right. Well, I want to thank again our guests. Hey, before we talk about what's coming up tomorrow, I want you to know about a special announcement coming up 2 hours from now. Join us back here at 10:30 for a news conference about a major announcement that will change the healthcare landscape across the metro and the region. That's 10:30 this morning. We hope you tune in. Jess, what's coming up tomorrow on the morning medical update? Besides you laughing at me, go right ahead.
I know, it's just I haven't seen you in a while. You were gone last week. It's just it just gets my Wednesday going.
I mean, I was having a cool time hanging out in Vegas for like 18 hours.
I know, right? Yeah, I think the shirt comes off in Vegas, not here. So,
Yeah,
okay.
maybe not.
All right. I'm glad you're doing well. Glad you're back. So tomorrow, we're going to tell you about an inspirational book that one cancer patient hopes will soon become a New York Times bestseller. So you're going to meet the author, and we're going to tell you all about the book. We'll see you back here tomorrow at 8 a.m. Have a great day. Coming up tomorrow on the Morning Medical Update. Facing cancer and losing your hair can be especially tough on women. It was for Cammie Crank, so she wrote a book about it. I'm Jessica Lovell. Thursday on the Morning Medical Update. Meet Cammie and how she's helping women face the expected and the unexpected chapters in their own cancer journey. See you Thursday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.